That's a good way to put it. Yeah, getting sepsis is almost as deadly as getting shot in the head.
And these immunocompromised patients are at increased risk over the general population.
You are listening to EMS with your hosts, Eric and Matt Ball.
Well, Enrique?
Yes.
Mateo?
Mateo? Is that? Oh, okay.
Yeah.
A lot of the folks that I've met from Mexico, they've called me Eddie.
Eddie?
Eddie? That's what they say. Yeah, I don't understand it, but actually, this
I would think Enrique
name.
would be Eric in Spanish. I would think. I don't know.
Oh, well, when I say Eric, they say Eddie.
Oh, really?
I guess. I mean, I know in Scandinavia, my name came from the name Harry.
Eric came from Harry?
Yeah, that's the origin of the name Eric.
Well, how do you say it in Scandinavian?
Oh, I don't even know.
Oh, maybe that.
I'm 100% Swedish. I can't speak Swedish. I've never even been to Sweden.
I do have some people that were missionaries in Sweden and speak fluent whatever Swedish. They would always do that when they didn't want anybody else to know what they were saying.
Oh,
it was a couple, and they would always, it's an interesting language.
We have a language we speak when we don't want people to know what we're saying. It's like the family kind of a thing.
You have your own.
It's kind of like Pig Latin in some ways, but it's not Pig Latin at all.
Well, there's that case. I don't know if you've seen that documentary on Netflix about that girl, the crash.
Yeah.
And then her and her mom apparently speak some form of, they call it Carney language, which apparently it's actually a thing.
Really?
That they call it Carney language, but they, on their like phone calls and stuff, apparently they use this language, and she did it. Like when the police were interviewing her, she started talking to her mom in this weird pig Latin-y kind of language. Yeah. And everybody was trying to, what is this language? And then somebody finally it's actually like Carney language.
Interesting.
So how did you guys come up with that?
It's actually something I brought into the family. My friends and I, a lot of my college friends played baseball.
Okay.
And they had this language they used that they would talk to each other. So the person standing on first base had no idea what the first baseman was saying to the pitcher. Because he would speak in this other language where you kind of just mix up the consonants and vowels and
ixnay, une, ime, or whatever.
Something like that, yeah.
Interesting.
And so we have that. We taught the family. Eventually, the kids picked up on it from Mom and I talking, right? Deb and I, we would talk, and then
she speaks Canadian.
That's true. She does. That's her second language. But the kids started to learn it. They got so smart. And
That's funny.
And now the kids speak it better than anybody.
Really?
And I can't keep up. Yeah.
I wonder how close that is to like that Carney language thing.
Yeah, you basically it's we called it ears language is what we call it, and so you'd say ears I, hears Av, ears A, beers I, whatever.
That sounds exactly like what they were doing.
Oh yeah. So it's when you hear it, it's like if I said I'm hungry, it'd be ears I, ears am, here's hungry. So it's hard to, when you know what
initially
they're saying, but when you start to talk fast, you'll get lost and you won't be able to understand it.
That sounds very similar to the language they were talking. So I wonder if it's the same thing.
Yeah, I wonder if it is.
That's interesting.
Well,
we are way off topic.
It's okay. It's okay. So we're going to talk about a population of patients today that are pretty common. In fact, a lot of people may not fully appreciate how common they are, this immunocompromised patient population. Mm-hmm. If you do a Google search for it, about 6 to 7% of patients.
6, 7?
That's right.
Is that why you did that?
Yeah, the number is actually 6.6.
Yeah.
6.6% of Americans are considered immunocompromised. Mm-hmm. That's not true, though. About 20% of Americans are elderly, which would be immunocompromised by their advanced age.
The young.
Yep. And the young, another population. Yeah. You can add dialysis patients to this. You can add patients who are septic. You can.
What's their criteria for calling somebody immunocompromised?
I think this would be somebody with a condition that makes them chronically immunocompromised. Yeah, transplant patients. We'll talk about them later, but it's actually a lot more common. And in some of the research we've done, I thought it was interesting, Matt. I see if you can figure this out.
Okay.
What state in the United States has the most elderly patients or the highest population of elderly patients? What state? Percentage-wise.
Percentage-wise, I would think probably Florida, a big high retirement area.
Absolutely agree with you. That's exactly the first place I went.
Did I get it?
It's not it. No,
it's not Florida.
It's not Florida.
Did I get a second guess?
Yeah, give a second guess. See if you can get one of the There are 3 states that were ahead of Florida.
Okay.
And none of them I would have predicted.
So Florida's the top 5. I would even think maybe Texas because the weather's here.
Yeah, a lot of people.
Warm?
Yep.
Is Texas?
Nope, it's not that.
All right, I'm lost. I only get 2 guesses.
Number 1 was Maine.
Really?
Number 2 was West Virginia. And number 3 was Vermont.
Oh, so it's just a percentage. So those are smaller states.
Yeah, there may be more elderly people in Florida.
Right, but it's
a
based on the
percentage
total
of gross population. Yeah, that surprised me because I would have thought Florida,
warmer states, not those are all northern states.
Yeah, that's I didn't think about it from that standpoint, but that's interesting.
But I do have family that live in the Northeast, and people from the Northeast do not leave the Northeast.
Yeah,
they stay there.
So this immunocompromised patient population is huge. So why does it matter to us in EMS?
Well, because it goes along with one of the most risky patients that we oftentimes take for granted because it's not the sexy patient, and that is the septic patient.
Septic patient.
That we sometimes, again, we take it for granted. People, this isn't that big of a deal. They kind of downplay the importance, but extremely high mortality rates, especially in immunocompromised patients.
In fact, you and I are preparing for, we're the speakers up in Boston soon, relatively soon, Boston.
Yeah.
And one of the topics they requested that we covered was sepsis.
Yeah.
And so in preparation for that, we learned some very interesting things. There's nothing more deadly in the hospital than sepsis. Yep. And there's nothing that costs the hospital more than sepsis.
And what are most patients in the hospital? Whether it's permanently or temporarily, they're all immunocompromised. Mm-hmm. Probably first, the majority of them
right.
are.
You're right.
Because they are sick or they just had a surgery or whatever it is.
Yep. Yeah, being sick can make you immune. Yeah, all those. You're absolutely right. So it's this is a real important patient population for us to be aware of. Mm-hmm. And I think the reason why we thought this would be a good podcast is that, or at least a good content for our curriculum,
for
I
CEs,
guess. Yeah, for CE, you can watch this for CEs. Is that a patient population like this can be missed if you don't get a thorough history. And if you miss it, you could potentially cause harm to these patients because it's been shown in literature that early identification, early treatment saves lives.
And I think that it's very complacency is the problem here because these are, the older people, which is the majority of the patients that we go on, the falls, the sick people, the nursing home calls. Yeah. And you go, we're going back to the nursing home again for the 3rd time today. And I get it. Yeah. But at the same time, these can also be some of the patients that are most at risk. Yep. And that we could have again, it's not going to be the cool trauma or we're not going to be activating the STEMI or, something like that. But we could have a dramatic impact on patient outcomes with this patient population. So it's very important that we understand it.
Yep. The elderly population is super susceptible to these things, and that's why we're talking about. So being immunocompromised, as the name implies, you've got a compromised immune system, and the immune system's our defense.
Yes.
So for some reason,
soldiers.
That's right.
Yeah.
It's kind of like leaving your doors unlocked at night, or your security system's failed. Yeah, your gun's not loaded.
Nothing more useless than an unloaded gun.
That's right. Well, anyway, yeah. So that's I think a good analogy for an immunocompromised patient would be like you not having a security system or leaving your car doors unlocked or open.
Yeah, you're leaving yourself. In my neighborhood, the police, which I'm very thankful for, actually, I live in a smaller town. And so the police will actually drive through our neighborhoods at night. And they will actually go drive around through the neighborhoods. And if your garage door is left open, they will kind of come in and they'll leave you a note on your car saying, hey, we stopped by at 3:00 this morning. And they will actually check door handles and say like, hey, your car door handles. And so, first off, it's nice that they have a presence in the neighborhood. And it's also nice. And I like to pass that along to my wife and daughters and say, see, lock your doors. Anyway.
Well, those police officers, law enforcement, it's like those white blood cells. They're circulating through our blood just like those officers are circulating through our community.
That's right.
Keeping us
the
safe.
bad stuff out.
It's a great analogy that you just brought up. And so a patient could have a neutropenic condition or a condition where they don't have a lot of white blood cells, which makes them immunocompromised.
That's right.
The elderly population is immunocompromised for a lot of different reasons.
Right.
Chronic conditions, medications,
age
stage alone.
Yeah, their systems don't work as efficiently as they used to.
Yeah, that's right. So, and then of course on the flip side, super young, they're going to have an mature immune system.
Right.
Part of what our immune system depends upon is being primed and exposed to things so we can develop a robust immune response that would defend us from potential invaders.
That's why it's good to let your kids have a fever, folks.
That's
if you're
right.
a young parent, don't throw them on antibiotics all the time. Let them build up an immunity.
That's right.
And,
letting the body fight off an infection is
so good.
Important.
For
it's the way we're designed.
I mean, exactly. Anyway, I was going to go off on another topic, but yeah, you got to let them fight a little bit. A little bit of a fever is not a bad thing. That means the body's doing what it's supposed to do, right? The immunocompromised patient's not going to have that defense system. So you should actually be thankful that your body's working properly and that you do have a fever, because that tells you my immune system's working. And you don't want to suppress it by constantly taking antibiotics. Sorry.
Now, there are some conditions. No, it's good. But there's some conditions where a regularly functioning immune system can be harmful to you.
Correct.
Sometimes people have an immune system that's ramped up, like with rheumatoid arthritis, an inflammatory condition. So we will take medications to ramp down the inflammatory response, just so we're not flared up all the time. By doing that, though, you are opening yourself up. You're immunocompromised. And that's why on those commercials, oftentimes they'll say, at 1,000,000 miles an hour, don't take those, death,
the risks at the end,
all these things.
All the side effects of this medication.
And oftentimes they'll recommend do not take if you have tuberculosis or have had tuberculosis.
Or they'll say do not take if you're immunocompromised.
That's right.
Another big risk. Yeah, exactly.
So that's what immunocompromised means. You've got your defense mechanisms are down, and there are a lot of reasons why you can have a defense mechanism that's down. There are a lot of, our skin, for example, our skin is part of our defense mechanism. Yeah. There are different levels of immunity.
Largest organ in the body.
Largest organ in the body. You've got a large wound, or you've got a skin condition, a burn, or whatever that can make you susceptible to infections.
Yeah.
You start getting down into the cells. You have a blood problem. That's going to limit your ability to fight off infections because of that, and you're malnourished. There's a lot of different reasons why pathophysiologically you could be hampering your immune system, putting you at risk for an infection, which again, like we talked about before, can have a really high mortality rate. Yeah, and we've talked about this, I think. But do you know how high the mortality rate of multi-organ dysfunction syndrome is in the hospital?
Oh, gosh. My guess, I'd say...
I wouldn't expect you to know this.
I would say between 20 and 30%.
And clinically, it doesn't really even matter. But as high as 80, actually.
Oh, 80? Wow. Well, that's what I meant. There was 80%.
Yeah, of course. Well, you're right, though. The most run-of-the-mill sepsis patients don't have an 80% mortality rate.
Right.
This is that patient I'm intubating. All the organ systems are failing. They're bleeding from every hole in their body. They're in DIC. These patients have a very high
you got to clarify that. I would have gone higher than 20%. I thought you meant overall septic patients.
By the way, what's the mortality rate of a shark bite, for example? Like, what are the chances of?
I remember this. I remember this from our trauma lecture. The mortality rate from a shark bite, I would say 10%.
Yeah, it's really, really low. Yeah. Super low. Lower than that even.
Was it? Okay. I know the fall from 60 feet, that was 100% mortality.
That was the worst. Good. Yeah, good memory. I'm impressed. You're good with numbers. But I was surprised that, usually it'll come down to the last two. Like a lot of people will switch up the first 8 of the top 10.
Yeah.
But the 1 and 2 were a fall from 60 feet
and it was a gunshot wound to the head. Yeah, right.
Well, you got about a 90% chance of dying if you get shot in the head.
Yeah.
But the fact that sepsis was close when you're in multi-organ dysfunction, syndrome.
That's a good way to. That's
80%.
That's a good way to put it. Yeah, getting sepsis is almost as deadly as getting shot in the head.
Yeah, the worst of the sepsis.
The worst of the sepsis, not just any sepsis. But.
You and I could go in your hot tub and
I don't have a hot tub.
I thought you did.
No, I don't have a hot tub.
Oh, it's a pool. Sorry.
I got it.
So you heat up your pool to 100 degrees. We go hang out in your pool. Yeah. And, we would actually meet SIRS criteria.
Sure. Yeah, right. It's all about context.
Yeah. We don't have the source of infection, but
exactly.
So we may flag for sepsis, but we don't have, not flag for sepsis,
clinically
but
shouldn't flag.
Screen for SIRS criteria.
It's like somebody's got a heart rate of 175. Does not mean they're an SVT.
Yeah. So you and I, we get sick, pathophysiologically speaking, we will be able to mount an attack or a defense against that invader. Yeah. And we'll probably be okay. We're relatively young.
Yeah.
Knock on wood.
Well, I'm older than you now, currently, for the next few months or month.
Yeah,
You're October.
Right. Yeah, I'm October.
Yeah, I'm older than you for the next 3 months.
That's right. Well, we're basically the same
Rookie.
age. I know. Basically the same age. And we are able to mount a defense against an invader, and it doesn't knock us out.
Right.
You're an 80-year-old in a nursing home, not getting a lot of great nutrition, maybe, a bunch of comorbidities, on meds and advanced age. You get the same infection then, you might be going to the hospital for IV antibiotics or who knows what. So anyway, so I think that's a big part of this, because that's really who's at risk.
Yes.
Is those immunocompromised folks are going to be more exposed to die of things that, the average Joe is going to be able to fight off.
So I think we should talk through so who all would you consider immunocompromised? I would say the biggest patient population pre-hospitally that we probably run that I would consider just broadly immunocompromised is the nursing home patient.
I think you're right.
Patient in a nursing home, not necessarily, just based on their environment. And they're older, which there's two factors that are going to make them immunocompromised. Most of them are going to have some sort of a medical issue. And again, I think that's a very common patient that we're running on. What else? What other patients?
Well, I'd look at the med list. I think another common patient population would be somebody who's taking a medication that would create an immunocompromised condition.
Steroid patients.
Steroids, patients
not
on
the
steroids.
muscle kind of steroids.
Not anabolic steroids.
Not every firefighter we know at the fire
on testosterone. No, there's a steroid is more of it helps your adrenal gland. It helps. There's a lot of different things that these steroids will do, and there are different classes of steroids. But anyway, so you're on a glucocorticoid like prednisone, for example. That's going to ramp down your immune system.
Right.
It's one of the side effects of steroids, but you're on it for a certain reason medically. Those patients, so you see somebody on a steroid, you see somebody on like a biologic, there's certain, like rheumatoid arthritis, there's a ton of medications. They usually end in an AB, like aducanumab or whatever it might be.
I've never made that connection.
And these biologics suppress the immune system. So the chronic condition you have isn't flaring up all the time.
Yeah.
But that, again, makes you immunocompromised because part of your immune system is that inflammatory response. So looking out for those medications, I think, would be what I would say, Matt.
Yeah, and especially that nursing home patient, you show up, they might be altered. They might have dementia or not responsive at all.
Yep.
And so you have to go off of that med list that the nurse gives you at the nursing home. Yep. And if you could be a superstar paramedic, if you're reading through that list and go, they're immunocompromised or possibly immunocompromised because they're on a steroid or whatever. So that's...
I guess another common one, like somebody's HIV positive, they're going to be on immunosuppressants as well. That's the treatment for those.
Right.
They can live a long, happy life on these immunosuppressants, but they do increase the risk of...
We have come a long way with HIV therapy.
We sure have.
A long way since 30 years ago.
Another common patient would be cancer patients.
Very common.
Yeah, you got somebody receiving chemotherapy
Absolutely.
or radiation therapy. These things can make you more susceptible because they knock your immune system down. Those new blood cells are very susceptible to these medications and the radiation treatments.
Yeah, typically they will be wearing masks shortly after their chemo treatments. For depending, a day, couple, or a week or something like that, they may be wearing masks. Somebody that's recently had surgery.
That's right.
Could be susceptible.
Yeah,
immunocompromised.
Diabetes and dialysis patients. I mean, there's a lot of different chronic conditions that can create a secondary... Eating
disorder patients.
That's right, malnourished, that's right.
So just thinking more the younger folks, right? We're kind of keep talking about the old and the very young, but you could have that teenage patient or early 20 patient that, is suffering from a eating disorder. And that could cause them to be immunocompromised.
A lot of these cytokines and chemokines that are made, to help with the inflammatory response, and not just those, there's many, many chemicals. Many of them are processed and made in the liver. So you have a liver patient with
Cirrhosis
liver problems. So
yeah.
they can also be immunocompromised, which is part of why that anorexic patient being malnourished would be, because you're not getting the proteins you need. Your body's not going to make everything.
Right.
It's going to be in survival mode.
Right.
And so you could be immunocompromised just because you're not getting enough nutrition.
Yeah. Right.
Well, I think we kind of covered all of those. That's a pretty thorough look at the different types of patients that could be potentially immunocompromised. Just having an infection can also, your body's so focused on an infection, and it can actually create an immunocompromised condition just based on you fighting another disease, whether the disease has knocked you down and created a malnutrition and a weakness, or
if you could have everything safe at your house, doors locked, bedside guns loaded, for those of us here in the state of Texas, but the guard dog and everything. But if 10 dudes with bazookas come through the door, that's going to be a little overwhelming. You're not going to be able to handle that, right? So you get multi-infections that are introduced into a body that's maybe has a healthy immune system, but it's just overwhelmed. Like, I can't fight on 10 different fronts at the same time.
You've used the word twice there. That was, I think, the key word is overwhelming.
Yeah.
You overwhelm your immune system, it's just not going to be able to fight off that next infection.
Even a healthy immune system. I think that's our point. Yeah.
So in addition to some of those other conditions like being sick and overwhelm your immune system, I think what we should probably talk a little bit about is the assessment. The EMS assessment. So when you're talking to your patient, sometimes we put on the blinders because we kind of know what's going on. This patient called for weakness, and you got the fever, you've got the vitals, and you're thinking, maybe you're thinking sepsis, right? But sepsis is a spectrum of disease. When you have an immunocompromised patient that is flagged for sepsis, it's like oil on a fire. The other problem too is oftentimes patients who are immunocompromised can't even mount a fever. Right. So don't rely upon fever for your diagnosis of sepsis. Again, you don't have to have all of the service criteria to screen in. Being very careful when you're looking to screen a patient for sepsis and activate, you may have an immunocompromised patient not even capable of mounting a fever. Right. They're just altered.
And I get that all the time when I'm teaching or when I'm reviewing calls, and I see like respiratory rates, 26, heart rates 120, all these things, but they were afebrile and they didn't cause sepsis. And it was a nursing home patient that just had surgery 3 weeks ago. It's like, this is screaming sepsis, but because they didn't have a fever, you didn't call sepsis on it. And so, I think that's a huge take-home point, especially maybe for newer EMTs, newer medics, that you do not have to have a fever. There's lots of reasons. Maybe they just took Tylenol, right? Or, something else to reduce their fever. Fever is not a necessary component for sepsis.
You can actually, tragically too, which is worse, you can even be hypothermic, which would flag you in. And that's... you get into those types of patients who are so immunocompromised that they, they're hypothermic in addition to all the other
hypotensive
things going on.
Now you're
big,
hypoxic.
You're getting up. Now the mortality rate's going up fast, and then you start you get that patient in your ambulance and you missed it because there was no fever. Now we're delaying treatment. We're just increasing the mortality rate just keeps clicking up, right? So getting them identified as soon as possible is a key.
Most follow your local protocols, but I think most heart rate over 90, respiratory rate over 20, possible fever, presumed source of an infection. Oxygen, new onset of oxygen dependence. Normally they're not a COPD or something like that where they have HOMO2. And now this person that's never needed oxygen before is needing a nasal cannula to maintain 94, 95%. The other thing that we've talked about numerous times, end tidal. If you have end tidal, put them on end tidal. I have had so many patients. I had one patient, was an older female patient, called us out for a separate reason. Partner, everything. She was walkie-talkie, but she looked weak and kind of frail. But my partner, as soon as he started checking vitals, because I was talking to the patient getting the assessment, and he's like, her heart rate's like 140. Like, why is her heart rate so high? Right? Context. Right? She didn't just get done working out. She's older. Why is her heart rate? She's in a calm environment. Why is her heart rate 140? But respiratory rate was fine. There was no other part of the search criteria. She was not a nursing home patient. She was at home. But the daughter did say that, I don't remember if it was COVID or flu or something to that effect. So there was a presumed source of a possible infection. But the only vital sign that was off was the heart rate was 140.
Oh, wow.
And so we get her out to the med unit, and I won't get too far into the story, but I was suspecting for a certain reason, I'm like, I think this lady might be septic.
Yeah.
And I threw her on end tidal. Her end tidal never went above 19.
Oh, wow.
Could not get it above. That was the highest end tidal reading I got. So I activated code sepsis on her.
Yeah.
And she had terrible
Was she altered at all?
Nope.
Or?
She was very kind of weak, but she was talking to me, A&O times 4. So I got a line on her, could only get 120 gauge on her. It's all I could get without, she didn't need to be bone drilled. She was normotensive. Blood pressure was fine, just the heart rate. Very good compensation. Yeah, she was compensating very well. But I called the code sepsis, and a nurse friend that if I said her name, you would know. And a younger doctor came into the room, and I was given the report, and he asked me, he said, why did you call code sepsis on this? And I said, listen, and this is what I tell people when I'm teaching, like, my job as a pre-hospital provider is to look for signs. Like we've talked about, I don't have all the tools. I can't pull a lactate, right? No. Which is the definitive sign that somebody... Huh?
End tidal, though.
Yeah. But, I looked at my end tidal. So, hey, look, my job is to look for indicators that somebody might be having a STEMI, that somebody might be septic. And from what I could see, I think this patient could be septic. I started an IV. I did the best I could for her. She didn't meet my criteria for cefepime, so I didn't give her any antibiotics. But if you're the doctor, you went to school for 12 years, I went to school for 6 months. So... But he's like, I don't think she's septic. I think she's just got, the flu or something like that. Take a guess at what her lactate was. Because I was curious. Well, and so I called this nurse later. Go ahead.
Make a good guess. And I know it's not a linear relationship, but 25, an end tidal of 25 is usually around 4.
Right.
So this now, I'm not sure exactly how steep the curve would be, but if you're below 20, I would say you're more than double that. I would say you could even be double-digit lactic acid. Maybe.
She was 16.
Wow.
Yeah, I texted that nurse friend of ours, and I'm like, I'm just curious, because I wanted to know, like, is this relationship between end tidal and a lactate, is it pretty accurate? Yeah, her lactate was 16.
And did they end up diagnosing her with?
Oh, yeah, she went to the ICU. Okay. I actually think she actually died a few days later.
Oh, wow.
She was extremely sick.
Wow.
Yeah, she went up to the very well compensated. But yeah, 16. And I was like, okay. So that one call sticks in my brain because I'm like, there is some truth, which I get. That's one call, and all the data people are going to be like, but data shows that, yes, an end tidal of 25 is typically going to correlate with a lactate of at least 4, which is an indicator of severe sepsis, right? 2 is a septic patient, 4 is a severe sepsis.
The most deadly thing, again, in the hospital, the most costly thing in the hospital, and that's why we're talking about this. Yeah. And these immunocompromised patients are at increased risk over the general population.
So throw them on that end tidal. It doesn't hurt to get an end tidal reading, right?
Yeah.
It doesn't hurt to do that. So use that as part of your
assessment
findings on these patients. But ask good questions too.
Get a full history.
Get a full history.
Every checkoff I do, it's always a tip that I'll give my new checkoffs. Like, you get a complete history.
Yeah.
You got a history, but you could have asked so many more questions. Now, there's a time to load and go and get a really sick patient, but when you can get a good history, so helpful to patient management. It may not help you every time. In fact, I told a recent checkoff this. I said, a full history on that motorcycle accident scenario that I had for you may not have really given you a lot of clinical information, but getting into the habit of getting a full history, it's gonna pay out so high dividends down the road.
And it's never going to hurt you.
No.
It's never going to be bad. There are times, like you said, on a motorcycle accident trauma, if somebody's bleeding out, I don't care if they're a diabetic. Like, I don't care right now, right? If somebody can't breathe and their O2 sats at 70%, I don't care. I need to do those things. But one thing that, and we've talked about this before, that I see most good doctors, most good emergency physicians that I have seen, they will always come in and do a good assessment. And I think a lot of times as EMTs and paramedics, we kind of take that for granted sometimes.
Yeah.
where we don't do that thorough, good assessment. We kind of take for granted, oh, it's just grandma that fell at the nursing home again, right?
Yeah.
And they don't do that good assessment where physicians know, I need to ask good questions. I need to do a good physical exam. I need to ask the right questions because, again, it might be that one question that you don't ask that's the key to figuring out what's going on.
I love the Swiss cheese analogy.
That's right.
Where, getting a good history, if you were, you've done this many times, you're giving me a patient, right?
Yeah.
You deliver a patient to me in the ER. You took a history, and you're not going to remember everything, right?
No.
And I'm not going to remember everything.
Right.
But when you line up your history with mine, you might remember something I didn't think to ask, vice versa.
Yep.
You might learn something. I might oh, shoot, I forgot to ask that. I'm glad he did. Right? I didn't ask about blood thinners, or I didn't ask about immunosuppressants. Oh, this patient's on chemo. Thank you.
Yeah.
And the problem is that patients, when they tell one person something, they think suddenly they told everybody in the healthcare continuum their story.
Yes.
So there's a misconception too sometimes with patients. It might be because they're sick or whatever, tired
embarrassed.
Or whatever, embarrassed.
Yeah.
But getting a good history is a big part of the assessment and not missing some of these potential risk factors of immunocompromised patients.
Yep.
So it could change your management. It could save a life.
Yep.
Knowing if the patient is immunocompromised.
And if you're a new EMT paramedic, use your sample, use your OPQ or ST. Those are good tools to help you so you don't miss anything. So
that's the assessment. So you get a good history. I like
physical exams.
Like I think the history would be the subjective information from the patient.
Correct.
Some of it's subjective as far as history goes, but what we can get from a patient without them talking to us. I mean, this is veterinary medicine now. You could get stuff on physical exam that could really clue you in.
Absolutely.
Whether it's a skin exam.
A med port.
Med port, very good.
Are you a cancer patient?
Yep.
Yeah.
That skin with radiation therapy is really classic. It's like a plastic sort of a feel. You've got that patient with surgical scars, dialysis shunts, indwelling lines.
PICC lines, exactly.
So a physical exam can be very important too, and that would include the lung exam, the very common source of infection for folks. So you get that patient that's a cancer patient that's dealing with bladder cancer, for example, that's on immunosuppressant therapy or chemotherapy, and you're doing a lung exam. Be common for them where you and I would fight off that lung infection. Right. They're not going to be able to mount that sort of a response and would end up being more susceptible to developing a pneumonia.
I'm also thinking of those chronically ill kiddos, the sad ones that, typically you'll get moved into your neighborhood. They have a nurse or an LVN that's an in-home care nurse and they're trached, and they're up in bed. I mean, talk about immunocompromised. They're like the definition of immunocompromised. Yep. All kinds of sources of infection. They're bedridden, so they're prone to having bed sores, and they're obviously their body's not working correctly. So another patient population.
Yeah, and those are part of those red flags, right? I mean, we can be in these situations where we're, not just on medications or whatever it might be. All of these things give us the clue. Hey, be on the watch. This patient's at risk. Really, I think again, early identification, early treatment's the key. Yeah. And if we're not noticing red flags, then we're going to have delayed care. Correct. And delayed care hurts people. That's right. I think we're all on the same page there.
Yep. Yeah. Vital signs. We touched on that a little bit.
We did, yeah. And again, the SIRS criteria. I like QSOFA better, but SIRS is fine. Yeah, they're both simple. Yes, there are better systems out there. I think the SMART, screening tool is probably better, but it's kind of complicated. Yeah, I think I like QSOFA better than SIRS, and I think the literature says it's better too. But good screening tools are going to catch a lot of patients that could potentially have sepsis. I would say in good common sense. Yeah. Like use your common sense. Yeah. Right? That you look at this patient, they look sick, they're coming from a nursing home, they're coming from a dialysis, whatever the case may be, and they just don't look good, and then their vital signs are meeting this criteria. Yep. Err on the side of caution. Yeah. Right? And activate. Because again, most protocols, you're going to have a septic protocol and then you're going to have your antibiotic protocol. They're not necessarily the same thing. Just because a patient is septic doesn't mean they're going to get antibiotics. The sickest ones should be getting antibiotics, and that should be pretty. Follow your protocols. Hopefully your medical director is explicit in the protocol. Differentiated treatment of different levels of sepsis. Yeah.
But fluids, I mean, there's not, and a lot of these patients, I know these were a lot of patients that were getting tubed in the field were septic patients because they were, in septic shock. And we're showing up. I remember one patient we had that was just totally altered.
Yeah.
And she'd been sick for days, and the family finally called when she was basically unresponsive.
Yeah.
And then we show up like, we got to take this patient's airway. Yeah. Like, she is super sick. Yeah. Anyway.
And I guess to add to that, I remember a patient, you just reminded me of a patient that brought in by family from the nursing home.
Shocker.
They were irritated, no pun intended, actually, thinking she was in shock, and that's why she was altered.
The family was irritated?
Well, the family was irritated that they were getting poor care at the nursing home.
Oh, gosh.
Which is a shocker.
Don't blame them.
I don't mean to be stereotypical there, but they were frustrated. I remember them bringing in mom. The grandma or whatever.
You know what? They were advocating for their mother, and I will applaud that all day.
Yeah, me too. Yeah. So they put her in their vehicle, and they brought her to the hospital.
Good for them. And they didn't call 911. Double good on them.
Yeah, right. So actually, they could have come in by ambulance.
Sure, yeah.
I'm not 100% sure, but they at least they got frustrated that they hadn't done anything about grandma who's altered. And she'd been in the hospital multiple times for UTI. And so they were literally frustrated that they weren't treating this UTI, that mom's altered again. And that's a classic thing, right? Yeah. Altered mental status in the elderly population. You got to check
with a UTI. Yeah.
So they were convinced of sepsis. And her urine, I remember, was kind of borderline. It wasn't that impressive, really. But she was pretty altered.
Yeah.
And on physical exam, I saw a hematoma. She had a head bleed. Big subdural.
Oh, wow.
And so an altered patient. So don't forget, too, it's like it would be easy sometimes in a nursing home to put on those blinders for a sepsis patient, especially with what we're talking about today. But I think this is always a good reminder to like on our cognitive bias lecture that we did not too long ago. Don't anchor on a diagnosis. Don't rest your laurels on the information you get from dispatch. Don't let the family frame this thing for you. Yeah, all that. These are things that our brain is always fighting against, and I think that's key. If you haven't seen the cognitive bias stuff we did, I think that was a great lecture. But to circle back to immunocompromised again, you get this septic patient, they could have something else going on too, right? So
again, context is super important, right? Look at the whole picture. Don't just zone in. Well, their heart rate's 130 and they got a temperature. They have to be septic. Like maybe they're hyperthermic.
No, right? Yeah, it could be a lot of things. Yeah, and that fever could be other things too. So I guess management. So how do we manage these patients? Well, I think, again, the patient population we're talking about is at risk for sepsis. So how do you manage a sepsis patient? We've kind of already talked about this already, but it's not
follow
as much
your local protocols.
Follow your protocols, but it's going to involve fluids. If they're sick enough, maybe some IV antibiotics.
Yeah. Do you like LR over saline for these patients?
LR for sure.
I do too.
LR, absolutely. Yeah. Now, if you only have saline, use saline.
Right, it's better than nothing. But
LR is a superior fluid for sepsis and for DKA. There's a lot of different conditions that LR is much better for. Where there's some that's like, either or. And there are actually some conditions where the NS is better. But for the purposes of this lecture, you're treating somebody who's immunocompromised that flags for sepsis. Yep. The fluids are going to be part of our treatment. Don't give too much, but give fluids according to your protocols. Pressors are huge too.
Maintaining that pressure.
That's right. And that's the tough thing too, because we're dealing with a patient population that tends to be old. With these immunocompromised folks.
Do you remember that patient we had in the back of the ambulance?
I do.
At the nursing home when you were riding out
with you. Yeah, I do. And we did some push dose pressors.
We did. We drew up a push dose pressor. Got some lines going on her. Yeah, she was. We didn't have the antibiotics back then. She might have been a candidate for it. But
that's right. Yeah, we just started doing antibiotics for open fractures recently and sepsis. Septic shock and severe sepsis is what we do.
Yes, that's same with us. Yeah, and then open fractures.
Yeah. Well, that's good. So let's practice a couple of these things, Matt. I got some cases here for us.
Okay. It's going to put me on the spot.
Well, we'll put each other on the spot here. We'll discuss them. I think this will be good. So the patient, you're talking to this patient at home. So we're not going to...
Don't throw it off too much. Don't give it away too much.
And the chief complaint is just fatigue.
Yeah.
Fatigue. That's it. Okay. So what could that be? If somebody's tired...
Could be a million different things.
Could be a million things.
Yeah, I need to get more information.
Yeah. So
what's their history? What's their meds? What's their vitals?
Right. Well, as you continue to talk to them, they've got lung cancer. Lung cancer.
Okay.
They're on chemotherapy.
So they're going to probably be chronically fatigued.
That's right.
Yeah.
When did you get your chemotherapy?
Yeah.
The patient condition right after chemotherapy is a whole lot different at the right before chemotherapy. But yeah, you get this patient now. You know they're immunocompromised. Are they altered? I mean, one thing to be tired, another thing to be altered.
Yeah.
What do the vitals look like? So yeah, that's good. So that's kind of the learning point there is that these patients are increased risk for sepsis. And do you remember why these patients are at increased that are on chemotherapy? It has to do with the blood cells. The chemotherapy is going to kill off those blood cells, so they're going to be neutropenic.
Oh, okay.
Yeah, so that's the learning point, I think, for that.
So
one.
they have less soldiers to fight off. Is that what you're saying?
Yeah. Do you want to do the second one?
Sure. Well, let's see. So you get called out for a mild. No, I can see it.
Okay.
Mild shortness of breath.
Okay, mild shortness of breath.
Yes.
Dyspnea. We talked about this in a previous podcast.
Exactly, in our hypoxic podcast.
Well,
so
same
very
thing,
common call,
huge
right?
differential. Very, very common.
Yes.
Shortness of breath.
Yeah. I
Okay.
mean, we don't have a lot of so you get on scene.
Lead me down the path.
Okay, so you get on scene, and let's see. We don't have a lot. I'm trying to.
Wow, they're short of breath. So they're breathing fast?
Yeah, so they're breathing kind of fast. Maybe their SpO2 is a little bit low.
Okay. Hypoxic.
Maybe a little hypoxic, yeah. Mm-hmm. And then they tell you they just recently had a kidney transplant.
Ooh, there you go. Yeah, so when you have a kidney transplant, you need to suppress.
Danger.
Yes, right. Flag, danger. You have to have an immunosuppressant on board.
Yeah.
Tacrolimus, or I think that's what they call it. Anyway,
it
doesn't matter.
I'm not a nephrologist.
When somebody's had a transplant, they're going to have to ramp their immune system down so their body doesn't attack a non-native organ.
Reject the organ,
Yeah, so that's a great red flag. You get a transplant, transplant patient, cancer patient, somebody with on immunosuppressants for a chronic condition, that should be a red flag to us.
Yeah, pneumonia, these type of patients.
Yeah.
I read the next one. Sorry. Oops.
Okay. Well, we'll skip ahead. Then.
Okay.
So let's see. So so you got a patient, and fatigue might be the complaint.
Yeah.
And you're asking them questions. And you ask specifically if there may be if they're on any medications. Common part of the sample history, right?
Absolutely.
So you're asking about meds, and you're like, most of the meds you recognize, but there's some weird ones on there.
Yeah.
And how would you be able to? Let's just talk about this because this is an important one. The medication, spoiler alert, is one of those biologics that's an immunosuppressant for rheumatoid arthritis, maybe. Mm-hmm. But, we don't need to memorize all these medications.
Google it.
You could look it up. You could Google
I have done that so many times in the back of an ambulance. Like, what does this medication do?
Or you could ask why they take it.
That's the other thing. Yes. What do you take
what
it
is
for?
this?
But even at that, though, I take it for my lungs.
Yeah, that's true.
That
you may
doesn't
not
tell
get
me.
enough information.
Yeah, exactly. So, I can't tell you how many times. First off, there's so many medications out there, right? It's important to know the classes of medications and what they do. But there's no way you're going to memorize every single medication that's out there. No. So, heck yeah, pull out your phone, your iPad, and Google that sucker and find out what it is.
And there are a lot of immunosuppressants out there with a lot of weird names, usually end with an ab, those biologics, and they can really create some potential risk for your patient. So that's good. That was case number 3. So the blunting the inflammatory response by these medications can create an immunocompromised patient situation. All right, try 4. So good one. We talked about this. This is a common one that we got to have this memorized. Yeah.
So you have a patient with hypotension.
Okay, so we are hypotensive and altered, and you're looking at.
He's got an adrenal insufficiency. Excuse me, and an occult infection.
So they're probably on steroids.
Yes.
And when you're on steroids, you're blunting your inflammatory response.
That's correct. Steroid patients. What are some common steroids?
Well, the common ones are glucocorticoids.
Right.
So dexamethasone or Decadron, prednisone or prednisolone.
I take Decadron for my steroids, for my allergies when they get really bad.
Oh, yeah. Well, and by suppressing your immune system, it can really bring a lot of relief.
Yes.
The side effect of these things, though, is you're putting yourself at risk
for getting sicker.
It can decrease bone density over time. Mm-hmm. There are a lot of different things that steroids can do. Side effects.
Negative.
Negative. Yeah.
With the good comes the the downside. With the pros comes the cons.
Right. So anyway, all right. Last, I think we have one case left. Is that right? One case?
Oh, we should have one or two.
Oh yeah, sorry, we have two left. Yeah. So a dialysis patient, how do they get immunocompromised?
Oh gosh. Well, they're almost constantly. I mean, they're getting fluid introduced to their body every couple of days, and they have a huge source of infection in their dialysis.
Especially if they could even have a temporary dialysis catheter, which can create chronic inflammation, which can create an immunocompromised patient. So, no, those are good.
Yeah,
so,
is it a CAUTI? What is it? The catheter? I'm
going back Quinton? A Quinton catheter? Or?
No, I'm talking about the acronym for the kind of infection. I'm going back to nursing school, which is about 8 years ago. So.
It's a catheter associated.
Yeah, I think it was a CAUTI.
There's a Foley associated, and there's a catheter associated infection.
Whatever, I don't know. The nurses out there will yell at me and say, "Hey, stupid! This was a question on influx."
Well, I used to be on the hospital committee on this thing.
Because this is a big deal, right? You do not want to get a hospital.
They're graded on that.
Yes. Oh, big time. Because that can cost you a lot of money. And those CEOs and CFOs.
They're publicly reported grades.
Yes.
And you got to report these things when they happen.
Yeah.
The government will give you a leapfrog grade, a safety grade based on these things.
It's got to be careful. Those PICC line nurses and those people inserting that stuff. Got to be careful.
Yeah.
Anyway, sorry. We digress.
No, that's good.
Which is another infection source, right?
Yeah.
These are all part of the same immunocompromised patient population.
Well, I think to kind of pull it all together, when we consider a patient that we're seeing, whether it's altered mental status or whatever it is, having an understanding of their immune system's functionality is important. Patient with, like that motorcycle patient I mentioned a while ago, that patient is not immunocompromised.
Well, actually, if you think about it, he is. Because he's a motorcycle patient, he probably got some sort of a big abrasion.
It's true.
And so now he's got a wound that is very susceptible to infection. Burn patients, highly susceptible.
The skin is a big part of our immune system.
Yes, again, the protection. Sorry.
No, you're right, though. I mean, it's hard to think of a reason why, based on some sort of an assault on the body's organ systems, where you wouldn't have some sort of potential immunocompromised situation.
Right.
But I guess my point is like even in a young person, with no medical problems, you got to be careful with these things, because whether they may be malnourished or, like you said, road rash or even massive hemorrhage.
Or have a chronic issue, have a chronic medical problem they could have been born with.
Or on medications. There's a lot of different things that could happen that could create a situation where we need to be on guard. But I guess the most important thing to me, and you may or may not agree, I think it's identifying the patients, because if we don't identify them early, we're not going to treat them. So I think being aware of these conditions that can create a problem with the patient's immune system, I think that's the big take-home point for me. Yeah,
identification is the biggest. The biggest part of it, because if you don't identify it, you can't fix it or help it to be fixed, right? And you're just delaying that care, whether it's you're not giving fluids or you're not giving antibiotics pre-hospitally, to I'm not passing along pertinent information to you or the nurses at the ER, and now it's delaying them further, and then all of a sudden it's an hour later and they get the lactate bad and they're like, oh my gosh, this patient's got a lactate of 6, like that doctor, not, taking it for granted that, I don't think they're septic, and then gets the lactate back and hopefully pooped himself when he saw that, going, oh my gosh, that paramedic was right and I was wrong. I love my doctors, but sometimes people get their belief systems that, this can't be that because I'm not seeing a fever. I'm not seeing, look at the whole picture, right? Do a good assessment. Look at what medications are on, all these different things. I always tell people when I'm teaching that as an EMT, as a paramedic, when you're doing your assessment, you're like a detective trying to solve a crime. Yep. And more information is not going to hurt you. No. The more people, the more witnesses you talk to, the more camera footage you find, the more evidence you can gather, the more information you get about that crime is going to help you point in the right direction. And so, not asking a question is not helping you.
Yep.
asking that question is not going to hurt you. It might be benign information that doesn't help you at all, but it's not going to hurt you. I'll give you a prime example. We had a lady one time, lethargy, every call we've talked about. She feels weak. She doesn't feel good. I've told this story before because it's stuck in my mind so much about, and it's not that I was like this great paramedic, but it was just doing a good assessment.
Yeah.
That it was during COVID. We showed up at this lady's house, older lady, the family called. She just doesn't feel good. She's really just drained and tired. All of her vital signs are perfectly fine, except she's a little bit hypotensive. And by a little bit, I mean she's like right around 90. Nothing crazy. Yeah. Right?
Normal for some people.
Yeah. Heart rate was fine. SpO2 was fine. Blood sugar was fine. Afebrile. She's alert and oriented, but she's just kind of tired and felt this way for a couple of days. And we're out in the med unit. Yeah, okay, we'll run you up to the hospital, probably thinking she's got COVID or something like that. And I had a newer paramedic with me, and I was like, you know what? We've done everything else. We had her on the 4 lead. Let's run a 12 lead on her. Mm-hmm. And we're in, and I'll never forget, they're doing the, because I've got my new guys I'm training, they're over putting on the lead. And I'm talking to one of the guys on the truck who's in the doorway of the ambulance. We're just kind of talking because I punched in. We're waiting for the 12 lead to print out. Prints out, she's having a massive STEMI. Oh. Huge STEMI. And as this thing's printing out, I mean, I was like, oh my God. Yeah. And so it was immediately like, we need to go now. And so, but had we just been like, this is just a sick old lady. We don't need it. And I'm not saying we do 12 leads on everybody, right? Yeah. But we had already looked at everything else. We were back there. I was training somebody. Let's run a 12 lead on her. No complaint of chest pain, no shortness of breath. Assessment is huge. If you don't identify it, you can't fix it. Sorry.
No. It's the same thing. That's what we're talking about. This is part of the history. They may be only complaining of fatigue.
Yes.
But you get a full history. It adds to the story of fatigue. It's not just fatigue. It's fatigue. They just got chemo.
Yeah.
Or it's not just fatigue. It's
I've been fighting this
chronic.
Bed sore for exactly. Nursing home patient, and you get their med list, and they're on steroids.
Yeah. You actually reminded me of another medication we got to be aware of too, especially when you're looking for sepsis. Is the medications that can alter the heart rate, like a beta blocker.
Sure. Yeah.
Like, well, hold on. We only have.
The heart rate's only 75.
But they're on a beta blocker, which can blunt the body's response. They're trying to compensate, they want to compensate, but because of the medication, the heart rate's deceptively low. Yep. And it only has to get over 90 to really flag for it. But you're right. 75 without a beta blocker, it might be 110. Yep. So those are real medications that have a real effect, and they can really affect the way that we would assess our patients, and we might miss something.
Yeah. So do a good assessment, check everything out. Don't get complacent. You find those things, again, use N-title. If you know your patient's immunocompromised, that's automatically a red flag, should be. Yep. If they have immunocompromised plus any of the SIRS criteria, I would be on high alert for them being septic, right? Yeah. Get those fluids on board. If you can give pre-hospital antibiotics, do that. Certainly activate so that, like you said, passing along that information to the receiving facility, hugely important.
A very common condition we can see in our patients that puts them at risk for some of the most dangerous conditions we treat in the hospital. Important content today.
That's right. And what's the most important diagnosis? What did you always say? What's the most deadly diagnosis?
No, what's the most commonly missed?
Missed. The second one?
It's the second one.
Yeah, that's what it was.
Be careful.
Anyway.
Be safe out there.
See you on the next one.
Thank you for listening to EMS, the Erick and Matt Show.